Three,
I was
2,
saying
1.
earlier, nurses typically do not like to be interviewed
Really? Why is that?
because we are the voice in the background.
The voice in the background.
Yeah.
Well, let me say, serious question. Traditionally speaking, I could maybe get that. Is that though maybe less frequent today? Have the roles not changed, but evolved some?
They have evolved. I think it's definitely more teamwork. But I came from an institution in Chicago where the residents and the interns, they were always pulling in the nurses to be part of the conversation.
Okay.
You were the ones that were the expert on the patient because oncology, they stay sometimes for 3 to 4 weeks at a time.
Mm-hmm.
And if you're working inpatient, you get to know them. So they're always looking at you for the answers, especially the interns.
Yeah.
So it's kind of funny. You're like, no, you're good.
I would
Bad
against
choice.
that. Yeah.
Well, then how does the intern typically respond to
They're
that?
like,
Or just
okay.
depends?
Well, because they know if they don't follow what what the nurses suggesting that they do, things will go really badly.
Yeah.
So
They're
real experts.
And this is probably a personal, or based on the person we're referring to. So the answer is, it just depends. But is there not the concept of a team?
Oh, definitely. I think oncology more than most disciplines.
Right.
Because if you don't have the team, you cannot take care of those patients.
Right.
Mm-hmm.
And those who have lived it know
Yeah.
that they get to know their nurses really well.
For sure.
Yeah.
Yeah.
Do you remember that experience?
Oh, 100%.
Yeah.
Yeah.
Yeah. Which is why they stick around. They love patients who are engaged. They want to do anything you tell them to do to get better because they know that it's going to be rough.
Mm-hmm.
They are also not just, and this is maybe jumping ahead, but they're not just the ones assisting with, the treatment, let's say, but they're also part of the advocacy team.
Oh, absolutely.
Because I know my personal experience, there were parts where, so I didn't have a central line initially, which today, of course, like that's commonplace. They don't even think about it. But the veins in my arms were so fried that, and the nurse knew it, said, "Hey, we're doing a central line, and oh, by the way, there was a four drug cocktail when we got to, it was either the second or third one, I can't remember which. Over time was making me more nauseous, and so they addressed that and said, you know what? By the way, we're also not going to put you out in this mass room with 30 other people around you watching things happen.
Right.
We're going to put you in a separate room and knock you out a little bit."
Yep.
Let's go. Cool.
Let's go.
Yeah.
But
So I do remember that. That was 25 years ago.
Well, and I think what's interesting is the nurses are the ones that are trained to know the drugs, the protocols. They know, I had patients that used to come in and they would look at me and they would immediately throw up. Like it was that quick of an instant recall.
Don't take it personally.
Oh, we would laugh about it later.
Yeah.
Because they were like, please don't take this personally. I'm like, no, we just need to get you in a chair and get the anti-nausea. But I started in the late 90s. And so that's right when all the
when you were 5.
Oh, I wish I was 5 at that point. But that's when all the new drugs, the Zofrans, the anti-nausea regimens really beefed up, and symptom management became such a cornerstone of what nurses did. And it was actually the Lance Armstrong and the whole focus on symptom management, which coincided with that, is when we started as nurses, picking up the pace of doing research on cancer symptom management, the whole trajectory of what we can do to make sure that if you're going to get the chemotherapy, how do you actually get them to get through it with some quality of life?
Right. Yeah.
And what can we do symptom-wise that a nurse's role can fulfill to make sure that we know this is what you need to piece together. These are how you can support the family. And a lot of that really started in the late 90s.
Yeah. That's key because I vividly remember, I think it was the doctor to tell me, okay, here's the medicines you're going to get, and here's the list of symptoms. You might get one, you might get all 12.
Yep.
Mm-hmm.
Everyone's different. And so, yes, I need to voice what I'm seeing, feeling, whatever, but having another set of eyes and ears who aren't being directly impacted is huge.
Oh, absolutely. Well, and then they teach the family members and they teach you that if you have these 5 things, this is what you can do about it. And you only remember like 2% of what they tell you.
Right.
But when you come back in on a frequent basis, they're the ones who can redirect and know exactly what to do.
Mm-hmm. Yeah.
So
Swedish Fish,
No, thank you.
Okay. They're smart sweets.
Well, I
They're
appreciate
sweet
the fact
and they make you smart.
that you're trying, Vince, that you're trying to be better.
Yes.
I did not realize the addiction of Sour Patch Kids.
I don't know if I'd call it well, yeah, maybe I would.
I don't know.
Therein lies.
The addiction is not as great as caffeine, but
yeah,
it's one of my major food groups.
The two together.
Yeah.
It's a lethal combination.
They often do join together. Yes.
Not good.
In the afternoon.
Good thing I'm following a nutritionist because that's part of the story.
Well,
you have to eat better.
There you go.
To get moving.
That's right. Agreed. Well, let's touch on those in the episode.
Okay.
Let's do it.
All right. Is this thing on? Hey guys, welcome back to another episode of the Summits Podcast. Thank you all for joining us on this particular episode from wherever you get your podcasts, or if you are joining us on the Heroes Foundation YouTube channel, thank you for tuning in. If you are doing so there and you haven't hit the little subscribe button or the notification bell icon so you can be notified when new episodes like this one drop, please click on those. You don't have to eat any fake gummy candies. You can eat the real deal, but please do it. It costs you nothing. All right, we have a special guest today that I know Daniel is certainly excited for because I've already heard Boiler Up like 5 times, which is fine. Julie Otte. Julie, welcome to the Summits Podcast.
Thank you for having me.
You're welcome.
For being here.
Why don't you provide our listeners and viewers a little background on yourself?
I am a proud Purdue Boilermaker nurse, graduated in, let's just say, 90s, 86. And then after that, went and worked up in Chicago and got my first job on the south side of Chicago and became an oncology nurse. Probably the profession that within nursing I thought would be the least on my list of options. But oncology at that point was the only one hiring because back in the late 90s, nursing was in a slump where there were not a lot of jobs that were open. Okay. Healthcare was changing and they were hiring patient techs versus a lot of nurses to try to balance out the budgets. And really we cycled to the point where you just took the first job versus today, as you both know, I could leave Indiana University and go to any probably practice and be on the floor within a day.
Yeah. So it wasn't a case of you deciding what area of nursing you wanted to go into. It was just what was available.
And,
which is really sad to admit.
Yeah. Okay. But today, obviously, there's correct me if I say this wrong, but there are more specialty options and yes. more finite areas of nursing.
There are more pathways for nurses who come out, especially with a bachelor's. So I worked bone marrow transplant at University of Chicago. I didn't even know what a bone marrow transplant really was going to entail. But I took a job because they were hiring. Mm-hmm. And I fell in love with oncology. These patients were amazing. They would stay on the floor for 3 to 4 weeks. And we would obliterate their bone marrow and then transplant them. So I was on a unit where we actually specialized in the unmatched donors, which at the time was really messy. It did not bode well for many of the patients I took care of. But, after a year of doing that, it wears on you. And so then I went outpatient and did chemotherapy and stayed there until I went back to get my master's. Went down to Nashville, Tennessee and got my master's to be a nurse practitioner in oncology. To really focus on the symptom management piece that we were just talking about where, I saw all these patients come in and we would treat them, but then they would survive having these horrible symptoms of, poor sleep or, women had hot flashes, like all kinds of things that we didn't really know what to do about. So I met this fantastic faculty member when I was in Nashville, Janet Carpenter, and she got recruited to Indiana University. And so I started working for her as a research assistant. Nurses don't really learn research in a way where it makes it really fun. It's very boring to learn, but I got a lot of hands-on experience. And I was like, that's what I want to do.
Nice.
So I wanted to contribute more. I mean, oncology really wears on you after a while. I mean, I was doing it for 10 years and all of your patients either recover or they don't. And, after a while, there was one patient in particular from Purdue that happened to be in Nashville living there. She was really, really sick with end-stage breast cancer. And after that, I was like, I think I need a break.
Yeah.
because you can't not get attached to your patients.
Yeah.
And that's that caring part of what nurses' role is. They're the ones who are flushing the central lines, giving the chemotherapy, and you see them decline. And after a while, it wears on you. Mm-hmm. So,
is that common? I mean, do you see that where, I don't want to call it burnout, but nurses get burnout in a certain area and either leave nursing altogether or just go to a different area of nursing?
Yes. And I think that is even more true post-COVID, which I hate to even mutter the words COVID in an interview, but it is such a part of our story now, the shift of what happened during those 2 to 3 years. All the older nurses that were probably close to retirement finally decided that they needed to just go ahead and retire.
Okay.
And it's left a void. Obviously, the workforce for nursing has shifted quite a bit. And then people just realized it was just too much. Every sector of medicine was so greatly affected by the shutdowns, the rescheduling, the masking, just the stress of it all. And so hopefully now that we have a lot of new graduates coming out of schools like, IU and Purdue, they have a fresh start. They have a different perspective of what it's going to be like. So, yeah.
So, what is the focus at the School of Nursing today? And I know it's kind of a broad question, but
it is a broad question.
Since you've seen nursing evolve and change somewhat over the last
because I'm old.
Few years.
I'm now over 50.
I did not say that.
I am.
You're as
Midlife,
mature as I am, or well, I shouldn't use the word mature when I reference myself. You're much more mature than I am. As you asked if we can curse on this podcast or not, which you already know the answer. How's it evolving? What the teachings in nursing school today versus 20 years ago? What are you guys focusing on now that was different?
Well, I think the way we teach nursing is different.
Yeah.
We used to be, it was here's the book, here's the lecture, you memorize it, you take a test and you move on. But now our students are much more integrated in the learning process where they have to sometimes present the content. They are the ones who we're looking at the concept and how it threads through the whole lifespan. It's not just, this is pediatrics, this is adult.
Okay.
So it's shifted a little bit on how we teach in the classroom, but I will say the technology is much more sophisticated than when I was in nursing school. I mean, there was still paper charts. We would still have to write our notes, but everything is electronic now, which is nice to some respect, but also it has shifted the fact that when you walk into a patient's room, the nurse now walks up to a computer versus before we would walk up to a patient.
Mm-hmm.
And so I think there's pros and cons, especially when your system shuts down and you have no electronics, then you are shifting a whole population of nurses into an area where they don't know how to write.
Oh my God, I have to speak to the person now?
They're like, I have no idea what to do. So I think our patients get that sense. There's not that sense that, the eye contact, but that's just technology in general and how it's infused. But, at the School of Nursing, our focus is really, it's producing really good nurses who are prepared to take on these roles and make sure that they don't burn out and that they know that there's career pathways and get them into a space where one of the biggest problems we have, there's not enough of me, nurse faculty who, or not just doing research, because that's what I do up until, my leadership role that I have at IU now, but we need more faculty that are trained to teach more nurses because that is the limitation that most schools of nursing in the nation are having. We don't have qualified faculty to be able to expand. So IU just expanded because we got a grant from IU Health. So Bloomington, Bloomington, Fort Wayne, and Indianapolis are under one dean. And so the rest of the IU affiliates have their own accreditation. So we're all striving. It's not just us. It's all around the country. We're trying to get more nurses in to the programs, but you're only limited by space and faculty.
Mm-hmm.
And so, the faculty, I don't want to call it so much a shortage, but we're gravitating towards that. You're competing with practice in terms of pay.
Sure.
I like the flexibility of it. And a lot of people who have families, you can teach but we can't produce more nurses if we don't have those things in place.
Right. Yeah. You mentioned research. So in addition to your teaching, what else are you doing?
Right now, I'm an assistant dean of evaluation. So all of the data that comes in on the quality of our program since I love data, I love to crunch numbers, I take that and I write all the reports for accreditation, for all the other leaders in the school who need the data to make good decisions.
Yeah.
So all, the student evaluations that you did as a undergrad student, grad student, I take those and we help the other faculty make decisions about where changes need to happen, all that, logistical stuff. So I do a lot of data crunching, a lot of numbers.
When you're at home, does Frank tell your kids, go to the dean's office?
The funny thing is he's always like, oh, it's a math question. Go talk to your mom.
That's true.
He will tell you he did not like math. And I taught undergrad statistics, which is hilarious. That
Really?
I don't have a degree in statistics, but it's how research matches up with what you do with data.
Sure.
Take the data to make informed decisions. And that was what geeks me out a little bit, because that's what nurses need to do. We need to use evidence to drive the practice. So traditionally, if you go back, 100 years, it was like, well, why don't we try to put the NG tube out this? We'll just see what happens, but the testing and the research wasn't in place. And so now we know we need to research it. If that's the correct placement, then let's do it that way, create a procedure so it stays the same. So we base it on good practice and data versus let's just see what happens.
Sure. All right. So I'm going to ask a dumb question, which I'm very good at. When you reference doing research in the areas of nursing, what typically, because in my mind, I'm thinking research, I'm thinking like concocting a new medicine that's going to perform better than what's on the market today. When you say research on the nursing side, give us some examples of what that might entail.
That's a really good question, actually, because a lot of people get confused that a nurse can get a PhD. So we do have a unique PhD in nursing. Okay. And it's, you have doctors that get MD PhDs. So they not only are they trained to do research, but typically their research is drug development, all that R&D that nurses can get involved. There's plenty of nurse researchers with PhDs that work for people like Eli Lilly and work in their research programs. But for me, it was researching what can I do in terms of a nurse intervention. So symptom management.
Okay.
So my specialty was sleep. I thought sleep was so fascinating because a lot of my patients would get past the initial diagnosis and all the way through the end of treatment, and they're not sleeping. And that is a big problem because without sleep, your whole body, especially as a young parent, if you've got 2-year-old, sleep is premium. Yep. And when you don't get it, things just fall apart.
Yeah.
Oh, that explains it.
Yeah. It explains a lot. Yeah.
But typically you transition out of that point. But a lot of these people, for whatever reason. So I thought sleep was fascinating and the physiology of it. How do we actually lay down and close our eyes and our brains shut down? So I did a lot of research to try to figure out what the problem was and how, not so much to give them a treatment, but to stop them from taking some of the treatments they were taking. People were taking Ambien and all of these, not that I'm not sure if I can name drop all these drugs, but they would be prescribed these drugs and those have consequences. They were getting up in the middle of the night, like binge eating, and not knowing why. So we try to do non-drug interventions. So how can we teach you to not eat ice cream before you go to bed? Like stop watching TV to fall asleep. Right. Those are all bad things, by the way, before you fall asleep. So
what if you put Ambien in red wine and watch TV?
Vince.
I'm not speaking on my...
hypothetically.
We will talk offline about those bad habits, but eat some more Swedish fish. So it's not, we create interventions that are more about quality of life and symptom management, which to me originally was like, this sounds awful. Like, why would I want to do that as a career? But when you add in certain wearables to find out, like, this is your sleep pattern. And patients are really grateful because someone has acknowledged that they have a problem. Because when you're in the medical system and maybe you experience this, not all doctors have the time to dive into every symptom that you are experiencing. So you hit the high ones. Like, I can't keep anything down. What can I do? Or I'm still having, and usually some patients walk in, they don't want to talk about their symptoms because they're like, I don't want my cancer to come back, especially if they're a survivor.
Right.
I just want you to tell me that I have a clean bill of health, but they could go home and still have all these pains, numbness and tingling in their hands from the chemotherapy. Right. you name it, head to toe, there's symptoms. So we try to focus on what can we do to learn more about it and then help them in a non-pharmacological way, whether it's, teaching them how to sleep better and getting people to actually do what's called cognitive behavioral therapy for sleep. Basically, you're changing your behaviors. And that's probably one of the hardest things for people to do.
Sure.
Is change behavior. And so I did a postdoc fellowship after I did my PhD here at IU. So I have a degree from IU and Purdue.
Yeah.
Although I only hung my Purdue flag out.
Sure.
Perfect. I like it.
I have allegiance to Purdue. So we, I did a postdoc in behavioral symptom management. So with that training, you're trying to really get people to change behaviors. And that is really one of the toughest things. I mean, think about it. Stop eating Swedish fish.
Right.
Vince.
I know. She's trying to get me on a smarter form of candy than the original Sour Patch Kids. And to your point, it's all about changing behavior.
It is hard. And that goes along with all of the front end of the cancer trajectory. And that's like primary prevention. Right. That is diet, it's exercise, it's, all the things that are super hard. When you walk into a grocery store, it's not as if there was a nurse that I think did research this. You walk in and what is the first thing in Kroger that you see? It is every sweet candy and cake possible versus putting healthier choices up front so that people don't automatically are like, I am starving. I am going to get those 5 things of cookies. The soft pillow cookies with the icing that all these kids are totally addicted to for every birthday treat.
Yep.
Because they're nut free. I'm like, well, they're not sugar free.
This is true.
Not good.
We replaced whatever nuts might have been in it with more sugar.
Absolutely.
Yeah.
And some preservatives.
So there's a lot of things that we could do, but people are very reluctant to change.
That's for sure.
There's not a lot of motivation. And sleep is just like diet. We control it.
Yeah.
We control all the aspects that lead up to our sleep but do we do it? Not always.
Right. So 7 hours still the recommended number?
It is. Yeah. Roughly. It's all about the range.
Right.
6 to 8 is optimal. Making sure you don't wake up every 10 minutes, ruminations. A lot of people are so stressed that they wake up and they cannot shut their brains off. There's a lot of sleep disorders that people have that go undiagnosed. So that was my recent research, is trying to figure out, if they're doing all of these things to help them sleep, why are they not getting diagnosed, or at least ruling out the fact that they could have sleep apnea or, other things that if you don't have a bed partner, and a dog is not a bed partner, if you don't have someone telling you that you're kicking your legs every night, unfortunately, Frank calls me Thumper because I'm always thumping my legs at night because I have restless leg. And so I don't know it. I'm like, dude, I was asleep.
Yeah.
Can't help you with that.
Yeah.
But, it's really bothersome and it's not good because you wake up exhausted. So, and when you don't sleep, you function the next day. You're like, I'm tired, but then you caffeinate, which is not good. And it takes 6 to 8 hours to process caffeine in your body.
I should be good for a while.
So think on that for a second.
Yeah.
Some people drink it all the way to the end of the day, and it does disrupt your sleep patterns at night. So sleep is fascinating. Yeah. Not everyone's like, why do you focus on sleep? I'm like, it's fascinating.
Yeah.
I mean, I'm not in that world. It sounds kind of boring on the surface, but to your point, like, it has implications in a lot of areas.
It does. And really, especially at the high school in nursing, we have a big cadre of cancer researchers who look at everything from cancer screening. How do we get people to, that's really an important piece. If we're going to do cancer prevention and control, how do we get, especially disparate populations, like, to get their mammograms, to get their colonoscopy? Who really wants to get a colonoscopy? Right. No one's really signing up to run into the prep and get it all done. But when you do it the first time, you're like, that's not so bad.
Right.
But it is really hard to get people to do. So we've had faculty who have, and they're nurses, they do all that research to get the behavior change, to get them to get screened. And physicians are focused on the treatment part of it once we actually get them screened and diagnosed.
Yeah. Intrigued to hear about kids that are going into nursing school today. What are you seeing? What number one, why are they going into nursing? Has that changed at all? Or is the impetus for them to go into that field, the same as it was 20, 30, 40 years ago. And I guess what area of nursing seems to be the most popular and why?
Oh, that's changed quite a bit, I think. Back in the late 90s, ER was the really common TV show. Everybody was binge watching it. Binge watching, that wasn't even a word back then. You actually had to click on a remote and turn the TV on and wait until 8 o'clock
that one
episode.
Right.
But today, I think the reasons, it's funny because we do have, we have some kids from Chittard, seniors that are headed somewhere for nursing. And I've talked to a few of them in particular. And I think they've never really told me why. I think they do like that point of taking care of someone, that empathy. Nurses, not everyone goes into nursing has that empathetic side, but they see job stability, and that's fine too. I mean, literally, it is the most stable job in healthcare. There will always be nurses. There's a lot of exciting places you can move to and be a nurse. If you're a nurse here, pretty much it's going to be the same if you're a nurse there. So it is a translatable profession. And so I do think people see that there's a lot you can do and it's flexible. You work 3 12-hour shifts and then you're done for the week. And you can still go and balance out because, this new generation, they're all about having fun and going out and living their life and traveling. And so I give them a lot of credit because we were grinding 8-hour shifts back then. 12-hour shifts were fairly new.
Yeah.
And unless you were in surgery. So I don't know really what area of nursing that many people are going into. I would say we supply a lot of nurses to IU Health. And so a lot of people like the babies. They want to go into the maternal child health. A lot of people still like the ER, critical care. They like that high adrenaline nursing. There's not a lot of people signing up for like what we call the med surg floor, which is the general sick unit. The ones that stay with chronic illnesses, come back and forth. You get a bunch of different varieties of things. So not a lot of people signing up for that. They want the high adrenaline, I feel, the higher pace, or they want to travel. A lot of nurses end up traveling. They'll go 3 months here, 6 months there, all over the country. Yeah.
You mentioned technology before. Technology has influenced everything, all of our lives, professionally or personally. What would you say are the 1 or 2 biggest technological advancements that have changed nursing, or either positively or negatively?
Well, I think positively, I do like the electronic reticle, the EMR, we call it, the medical record. I think that it does put the data into the hospital's hands much quicker. So that you can determine, and that's, part of the movement. You have to get paid by the insurance companies. If you have the data, you can see where your safety issues are. And I do think for better, for worse, it's definitely, but the counter part of that we talked about is that we're behind a screen with our patients. I mean, you go even outpatient to see a doctor. Now there's doctors that have scribes, that there's someone there taking notes for them so they can refocus on making eye contact with patients, being more physical and hands-on. So I think it balances itself out. I do think it's a positive thing. I think what I struggle with the most is hearing nurse managers talk about how much the new nurses and generations, and not globally, they have their phone on them. And so there's that constant distraction. And I would be curious if someone would research. This would be a great research for one of the nurses. Like how much has medical, mistakes or whatnot been influenced by nurses being distracted because they have their phone and their personal phone is buzzing, and they have a phone over here for their patient's call is now sometimes a phone. So I think for better, for worse, it's something we all have to deal with. It's not going away, sadly.
Yeah, and you can't like say, okay, well, as you start your shift, you have to put your personal phone up. That would be dicey. Well,
and I don't like when I see these news blurbs about a nurse who's posted something on TikTok when they're at work. I'm like, what is the point of that? I really struggle with the Instagram, TikTok, where they're at work and, they're broadcasting something that really should not be part of the profession. It just really, to me, diminishes the importance of what they're there for. It does tell the story. So someone would probably attack me and come and say, well, they're expressing their voice, but I don't know if that's the right venue to do it. So I think there's some shifting that could be done there. Find the appropriate time.
Right. You're a big TikToker, aren't you?
Oh, huge.
Yeah.
I wouldn't even know how to use it. Oh my gosh. If my daughter watches this, she's going to be like, I don't even have Instagram. So my husband and we are a no social media pair. We have vowed ever since it was MySpace. I'm like, I'm not that popular. I don't think people are going to be that concerned about what I'm doing. Don't want to see me, but it has connected many thousands of people.
It has.
It has. I mean, it has its positives, but just think of all the negative aspects, even if it's just a pure time suck that you've avoided. It's not a bad thing.
Yep, it's not a bad thing. I mean, I always say in academia now what we're dealing with is how do we handle AI?
Right.
And so I don't have an answer for that. I go to some sessions in a research conference and they're like, it can be used to your benefit. But then we have faculty talking about the fact that they have to validate every assignment.
Right. So, Daniel and I were talking about AI end of last week. I was at a conference a week ago, today, as a matter of fact, and there was a speaker on AI, just kind of in general. Because the people in the room, there were some older folks who've heard of AI but have never tried anything, haven't tried ChatGPT yet or anything like that. And other folks in the room who've already started to adopt it. And it was a very generalized conversation. But to your point, there are going to be a lot of aspects where it's very positive, but there's also some things that are pretty freaking scary.
Oh, absolutely.
And we're
Who's
just
making the decision?
Right. Yeah.
ChatGPT or the physician?
Well, and if you don't know any better, how do you know if that is accurate or not?
Well, I believe there was one comment that someone said that ChatGPT did pass medical boards.
Okay.
Which is really scary.
That is interesting.
That
is interesting.
It would be interesting if they, could pass nursing boards as well.
Yeah.
Not that they would be able to do that during it's a controlled exam. So,
yeah.
But if you're there in practice, you're all of a sudden you're like, Siri, how do you address a wound?
Yeah.
And Siri's giving you the answer. It's probably not a good practice. It's not evidence-based.
Not warm lemon juice.
Yeah.
No. Okay.
Pretty sure that's not the answer.
Yeah. Well, that's a good thing I didn't go to nursing school.
I would love to see that though.
Yeah. Well, what I just envisioned in my head really quickly was not a pretty
was not what?
No. And I don't think nurses wear the old school, like, white shoes with the thick soles and the white
nurse cratchet
dress and the
little hat. Yeah.
That's been gone for quite a while.
Yeah. I know. I'm out
Actually,
of touch.
I think I was right on the verge. It was probably 80s when we finally ditched the
You're probably the one that
cap.
did that.
Yeah.
You probably went in and said, hell no.
Does not fit on my permed 80s hair.
Well, yeah. Did you bring a photo of that, by the way, for the episode? We could put it up? No?
Hell no.
Okay. Fair enough.
Absolutely not. But I do believe my children found a picture of that at my mom's house recently. And I was like, I will take that. Thank you.
Yeah.
I need to dispose of this.
Right. Well, Julie, what is your cancer story?
So if I had to talk about my cancer story, I've had personal experience, obviously. One is a very recent, which was devastating, but really it's all the patients that I've cared for. Each one that I have cared for has been an integral part of who I am today. And I'm always grateful for those stories because, they opened up their minds and their homes sometimes. And, when I went in doing research or whether I was on the floor taking care of them, they always wanted an ear to tell their story. So their story is part of my story. Many of them have sadly passed away. Some of them I still get Christmas cards, and I value those tremendously because those relationships are very meaningful when you're an oncology nurse.
Yeah.
Because the amount of time you spend with them is incredible. And you have to sit down and listen to them and teach them, and then you hear their story. Some of them have been hilarious. I mean, the number of times that we use humor to connect with those patients who are willing and open to that. So, I mean, it's been a good career, but that it is definitely the times I sat in a hospital room and talked to my patient, and he, in my late 20s, I didn't know anything, gave me some of the best nuggets that I still carry forward with how to live life, how to be a good person. So my story is solely based on theirs.
Well, and you're interacting in a very raw state, meaning, you're seeing people in a very vulnerable state. I still to this day remember the primary nurse that I had most times. She saw me puke all over myself.
Absolutely.
Multiple times.
Cool.
I mean, the first time I did that, I was literally in like the general infusion room and there were like 20 people around. And as embarrassed as you are, like everyone's like, I get it. Been there, done that. Can I get you a towel? Well, let's all help out. Like, yeah.
Yeah, but it's awful. And it's raw. And especially, I mean, how old were you?
26.
Exactly. I mean, that's the thing. You were just breaching out of adolescence for the most part.
Right.
I mean, we consider 26 maybe an adult and not much anymore, but you connect with them and you probably, if you had a choice, you would ask for the same nurse every time because you develop that intimate relationship almost with them. And that's why I said, that one patient would come in and immediately throw up when they saw me. And we would laugh about it, and we'd clean it up. But it was just part of it.
Yeah.
But their stories and their strength are incredible. I mean, some of the just incredible stories of survivorship through a horror, but then dying with grace. And we don't talk about that enough. I've seen an example recently where someone truly died with grace. And that doesn't happen very often, but you have to be prepared and open for the tail end of the story. And that's not always hard for families to talk through. More needs to be done. We have faculty at the School of Nursing that really are focused on end of life and preparing end of life and being realistic about what that looks like. But you have to be ready to listen to that and be ready to prepare for it.
Yeah.
So it's the whole thing.
Well, we thank you for what you do and training the next generation of nurses, that they make a huge impact. I'm a witness to that firsthand, but I think everyone would agree. And we want to thank you for being a beneficial, productive board member of the Heroes Foundation.
Oh, thank you. It's been my pleasure.
Your personal support in that endeavor means a lot, and so we greatly appreciate that.
Well, I look forward to doing more, and especially as we enter into May, it's National Nurses Week, the 6th through the 12th.
Okay.
So shout out to all the nurses during that week. It's an important week to really acknowledge. I don't know if many nurses would be like, it's, but they do. They do hard work, really hard work every day. They're the ones who clean up the puke.
There you go.
And on that
bombshell.
And on that one, there you go. Okay.
Well, thank you for being here.
Well, hey, we appreciate your time. Thanks for coming in.
Thank you.
We knew you were so excited to come here and do this podcast episode. I mean, it's only a Tuesday on this day of recording, and she contacted me 3 times already this week. Like, I can't wait. Can we do it
she
today?
was buzzing on social media about being here.
I was tagging my TikTok.
Yeah. There you go.
See? Perfect.
Thank you both. You made this very painless, so I appreciate it.
Well, we tried.
No problem.
And thank all you guys for joining us on this episode of the Summits Podcast. We appreciate you all tuning in. Don't forget to thank your nurses and appreciate what all they do for the patients that they serve. And don't forget, guys, last but not least, beat cancer.